Okay. So, Dr. Tamimi, is it okay if I call you Dr. Tamimi? Do you want me to call you in any other way?
Just just call me Sammy.
Sami,
Much
okay.
easier.
Okay. So, Sami, thanks for being here. I'm so honored that you accepted my invitation.
Thank you so much for
And
inviting me.
I'm really thrilled to have you and to talk to you about your book, Searching for Normal. And thank you for to your publicist for sending me this copy. I read it as an ebook, and I'm so glad that I have a hard copy now. Um, so, Dr. Tamimi, I've been following your work, and you've been such a interesting and loud voice in this critical approach to psychiatry. And in my YouTube channel as well, I've been talking about your book so much. I talked about Foucault and other kind of intellectuals who are critical of also psychiatry and how it plays out as a political power tool. And I talked to you. So I talked about your books on so many different occasions on my YouTube channel. So you're a celebrity. Like I name call your name all the time. First of all, I wanted to ask you about the backlash that you received personally, because even like on my ADHD video, which I basically talked about your book, and I was just a vessel about like what your arguments are there, and the backlash in the comment section was very intense, and people seem to take it very personally, and people are just so uncomfortable about these kind of more counter uh, mainstream narrative arguments. So like professionally, personally, what kind of backlash have you received?
Um, I've had some issues in the past in my professional life with my employers and sometimes with some of the other psychiatrists. But I've also found that when you work in a mental health setting and you work with professionals from other backgrounds, like therapists, psychologists, specialist nursing staff, actually, when you get to a chance to speak to them, a lot of them, and I've been doing a lot of workshops to various people from various backgrounds, professional and lay, but a lot of people are wondering what the hell is going on. Why have we had so many more people being diagnosed with these conditions?
Mm-hmm.
Why has it so many more children having these mental health difficulties? Why do things appear to be getting worse? What is going on? So I think there's a lot of people who are um, maybe sometimes secretly questioning what is it. So actually, I've come to the conclusion that the um, arguments I'm putting forward, some of them are opinions, but most of them are simply a restatement of the factual, of the scientific situation,
Mm-hmm.
is the majority opinion amongst mental health professionals. I think the issue we have is that the public narrative, or what the public tend to hear from those who have institutional power, is actually a minority opinion now. It's a
Mm-hmm.
minority opinion because it's not scientifically based. It's a cultural system.
Mm-hmm.
So I've had some backlash, but not as much as you might think. And
Okay.
since I've published the book, I've done quite a few public events, and each time I've been warned, you know, prepare yourself because there's going to be people there who are going to be very upset about these opinions, and it just hasn't happened. It,
Okay.
it's it really just hasn't happened, and I think again that's because there's a lot of people who are asking these questions who are quite confused. So I've done quite a few of these presentations, and it's not been unusual that after I finish the presentation, people come to talk to you and so on. And I've had several people come and talk to me who are saying, I'm really glad I came and listened to you, because
Mhm.
I've just had an assessment for this, that, and the other. And now I don't think that's the right way for me to go. Now I'm kind of thinking, because, and I was worried about what it meant that, and I've also had from professionals coming to me after these presentations and saying something similar. Okay, now I get it. Now I understand why nothing seemed to make sense to me. Why I kept having this feeling that what we're doing or what we're saying doesn't sound right. So strangely enough, I'm still waiting for the pushback. I
Okay.
do. I
Well, we
do.
can
I
visit
do
my
have.
comment section.
I do. I mean, maybe the other reason is that I was. This is Searching for Normal is. I've written several books before, but they've largely been for a niche audience, mainly
Mhm.
academic, mainly critical audiences, things like that.
I've also read
So
Rethinking ADHD and
yeah,
your book on autism as well.
yes, yeah, good.
They were also
So
great.
this is the first book that's a more commercial book, so more widely publicized. And my publishers and publicists said I should go on social media. So I'm trying to do social media, mainly X, I think, but I'm trying to do some of the other ones. But I'm really not interested in social media.
Hmm.
So I don't really read the comments. Every now and then I read comments, and there might be critical comments, and I think, well, that's fine. That's your
Yeah.
opinion. I'm not going to meet you. You mean nothing to me, so why should I take it seriously? So maybe that's also part of the reason why it doesn't feel like I've had pushback.
Okay. Well, it felt like you had pushback to me, according to my YouTube comments. But I'm glad that that you didn't experience that negative backlash. So I studied in the University of Manchester. Actually, I studied philosophy.
Okay.
And I'm a philosophy teacher now, and also so I have a philosophical background, and that's what I feel like I have more expertise on, and I'm teaching an AP psychology course. So I was always looking at like what I'm teaching critically from an epistemological perspective, from a philosophical perspective, and I'm like, okay, some of this data doesn't make sense, like it doesn't hold up, it's not as
Yeah.
scientific as
Yeah.
this curriculum makes it out to be. So I was very inspired by your work, because it's kind of made all of those clouds of questions concrete, and also you're coming from the field, so your expertise is immensely valuable as well in that respect. And I was wondering, as I was reading your book, you mentioned in your book that your formative years were in Iraq. You grew up in Iraq, and I'm living in Turkey. I've been living here for the past like 32 years, and I this is my theory, but because you experienced both that Eastern kind of Middle Eastern mentality and that very Anglospheric Western mentality, I think that kind of contributes to your how you can think outside the box and take another perspective. Do you think that your background contributed to your critical stance in any way?
Yes, I very much think that's the case. Well, I came to England as a 14-year-old. This was back in 1978 when the political situation was deteriorating, because I have an English mother
Mhm.
and my father was from Iraq. And I was sent to stay with relatives in England. My older brother was also sent to stay with other relatives in England to try and escape the situation, with military conscription age coming and so on. And it was a very disorientating experience when you realize that the sort of unwritten rules of how you're meant to behave of the social expectations were so different. And it was also my first experience of being an outsider, of being of experiencing bullying and being treated in certain ways by a peer group. So that is one of the things that I think helps you appreciate that there are different ways of understanding and living in the world. There's almost like a different systems of truth, different systems. But in some ways, it goes back even earlier than that, because when I was growing up in Iraq, I was very close to a lot of my extended family, and particularly some of my cousins who became very religious. And so they were older than me and used to talk to me a lot about religion. And then my parents were, my father in particular, was a follower of Lenin and socialism. And,
okay, I think we had the same father.
Yes.
So he was a fervent atheist, I assume.
He was, yes. And so I would come back and have these discussions with him. And so even then, I was already being exposed to the idea that truth claims, that there can be very different ways of looking at the world. And then when I started my training in psychiatry, and I was very interested in psychotherapy early on, and I started reading the classic psychoanalytic papers and books from people like Sigmund Freud and Carl Jung, but also the being exposed to the psychiatric literature. And of course, I had an interest in cross-cultural psychiatry. And from very early on, I thought, this group of people are looking down at my culture. The way it was written, that there was talk that's been going on for a long time about the civilized world, and the rest of the world is sort of mired in superstition and not yet psychologically developed to the extent of the civilized world. So that kind of colonial mindset was running through a lot of, and the same with psychiatric literature. It was assumed the categories that we were using in psychiatry were the universal categories, but when you didn't find them presenting in the same way in other cultures, it's because they were not psychologically minded. That was a common one. In other words, depression is the same. It's depression all around the world, but in other cultures, people present with physical symptoms because they're not psychologically minded. They don't present with, so.
So sorry, I don't know, maybe you've heard of this book called Crazy Like Us, the globalization of the American psyche. I also made a video on that. So like our interests overlap a lot.
Yes. Yeah. So that is an important book. And it's a very nice book because it's easy to read, and you see those concepts in very easy to understand language. But there's a lot of people who are writing about these issues. And a close colleague of mine who sadly passed away earlier this year, Suman Fernando, wrote a lot of really important books and papers about these issues. Derek Summerfield is another one, China Mills. There's a whole host of people. This is stuff that I started coming across as I became more curious about what's going on here. And sadly, initially, I had internalized that idea that I had come from a psychologically more primitive culture.
Yeah, you self.
It took a while. Yes, it took a while to realize, hang on a minute, what's going on here? And of course, in Western culture, there's a much stronger individualist orientation. much stronger idea that the self resides within, and a focus on the self and a focus on how you're feeling, and as if
Not
you're
focused like an
autonomous.
obsession, I think. It's like to an unhealthy level. Like
Yeah.
you also mentioned in your book, like that much inward looking is good for no one. Like, and you
Yeah.
need to turn outward, maybe. So I was because I received a lot of backlash, especially in Turkey. I think it makes some more geographical, cultural sense, because everyone's like, we're just, you know, trying to reach up to the level of the Europeans in terms of positivism and what you call the scientism. Like, we need to be looking at the positivist way of life, like scientific knowledge is the only valid knowledge. Why are you being critical? We're just reaching to the point of, you know, what Europeans accept and globally accept as a knowledge, valid knowledge. So I think there was, especially in the Turkish psychiatric psychological context, the backlash I received is due to that as well. We're like, they're like, or our people are already spiritualistic, why are you making them question the scientific authorities, kind of thing. And lots of psychiatrists wrote to me like, you're sharing these ideas, now people will negatively react when we try to prescribe them medicine. And I'm like, okay, if it's not good for them, then why are
Good.
you like
They
still
should. Yes.
prescribing it?
Yeah. Yes.
Yeah.
That's
Okay.
so. That makes me think of Frantz Fanon.
Mhm.
Frantz Fanon, who wrote two very important books, uh, Black Skins, White Masks, and The Wretched of the Earth.
Yeah.
And he spoke about this dynamic, it's a dynamic that is very familiar to me.
Mhm.
And it's the dynamic between the colonizer and the colonized. So there's a part of the colonized who are envious, who believe that the colonizer has all the special goods and they're keeping it
Mhm.
away from them. So you have this complicated relationship of animosity towards the colonizer, but envy as well, an idea that they are superior.
Yeah.
And so we kind of, I still sense that from my contact with people in Iraq, that and my dad's contacts from people in Iraq after we came to the UK, is that there was still a sense that the really good things are held by the West.
Yeah.
And that in order to, that we have to try and get to the standards of the West.
Mhm.
And this kind of dynamic between that and also animosity towards
Mhm.
these people who have done so much damage in your
Yeah.
country. So there is that kind of dynamic, which is it's a kind of internalization of that inferiority that the colonizer has put onto you. But the point is about all of this is it's not scientific.
Yeah.
It's a system of myths. And what you're trying to do is trying to help people understand that just because it comes from the West, that's just a commercial thing.
Yeah.
It's got very little to do with science. That's illusion of science is what I've been calling scientism in my book.
Mhm.
We're worshipping it as if it's a faith, just because it's said by people who call themselves scientists. We think it's
Mhm.
science, but actually it's upside down science.
Yeah.
It's not real science. It's, proper science. You come with a hypothesis, like there is a condition that we're going to call attention deficit hyperactivity disorder. It's located in the brain. We're going to call it neurodevelopmental, and it's genetic. Okay, put forward that hypothesis. In science, you put forward a hypothesis and assume it's incorrect.
Yeah.
You assume it's incorrect until you have evidence to show that it is correct, that you can back your hypothesis with empirical evidence. You don't expect your critics to be able to show evidence that it isn't correct it's the other way around. All the critics need to do is to show that, well, you haven't proven your hypothesis yet.
Mm-hmm.
And that's what I show. I've been following the research. Nobody has found a specific characteristic bit of the brain that's different or that's abnormal.
Mm-hmm.
Nobody has found the genetics. These are all missing. So this is what happens in upside down science. In upside down science, you assume that what you've hypothesized is true, and you tell your critics to come up with the evidence that it's not true. That's the wrong way around. So that's the problem.
Yeah.
They're publicizing things that are not scientific under the illusion of science, and people need to know that. It's a con. Yeah. It's a big con trick.
Mental health industrial complex.
It is. That's what it is. Yeah.
So in your critique of the medical model, but you don't just target ADHD or autism, you also target some other more neurobiological looking disorders like schizophrenia, bipolar disorder. So many people might agree with you on your critiques of ADHD and autism, but there is this common conception that, you know, schizophrenia and bipolar disorder are more on the side of like brain diseases. So what do you say to that argument?
Again, we have a hypothesis, and there is certainly some a small minority at the moment that we know could be experiencing a brain disease. So there is some rare conditions that we should be testing for with people who present with more psychotic presentations, such as something called anti-NMDA autoimmune, so that you can get some autoimmune encephalitis, which is inflammation of the brain. That often presents with a phenomena that's more closely tied to something called thought disorder. The person finds it very hard to put thoughts together. But there are plenty of other things that come under that idea of a disease like schizophrenia, and I've certainly come across quite a few in my own practice. So, for example, it is assumed that if you hear voices that are not there, what we call auditory hallucinations, these are perceptual abnormalities. They are perceptual abnormalities. You're perceiving something that's not there. But for many people, these are meaningful experiences. We have not been able to demonstrate that there is any chemical imbalance or other neurological abnormality. There is a greater likelihood that the people who present like that have experienced broadly adversity. They've often had difficult things happen in their life. And one of the problems with going down the route that this is an illness, just like any other physical illness, there are many problems of going down that route, is that you treat the experiences as symptoms. And when you treat experiences as symptoms, you take any meaning out of them beyond the idea that there's some sort of, this is some sort of abnormality that needs to be controlled or prevented. So it becomes meaningless torture. But quite often the content of these hallucinations are very meaningful to the people who are experiencing them. And quite often they connect to things that have happened to them. And one of the things that then happens when you call these things symptoms is that you, and they carry on, and if the best that you can do is suppress them or control them and convince the person that that's what is the thing that's needed to do for them to be able to get on with their life, then you're going to expose them to very heavy-end medications. potentially for the rest of their life. And these types of medications are associated with all sorts of side effects that make it very difficult to function. So there's lots of evidence out there that people who manage to come off these medications, or who manage to keep the medications at a very low level, in the long term will function much better than those who stay on these medications. And I've also had that clinical experience. And there's also various.
There's a case of Adam in your book.
Yes, and he's not unusual. I've seen a lot of people over the years who've had symptoms of psychosis, and you do have to consider whether medication might be important, even if it's for a period of time, because people in psychotic states can be highly aroused, emotionally very intense, and they can be in quite dangerous states of mind. So I'm not against medication, but the important thing is to understand that medication is not the treatment. It is an adjunct. It is something that you're using for a specific purpose. So there's no such thing as an antipsychotic. That's just a marketing term. But you do have to be very careful if people are on these things called antipsychotics. I wouldn't stop them suddenly if they've been on them a long time. So I need to make that clear. But there's a lot of people who I've worked with who've had these psychotic symptoms. They are meaningful to them, and they are meaningful, full stop. And one of the things that working with them is not about, if you treat it not as a symptom, but as a meaningful experience, then the task of therapeutically helping someone is not about getting rid of these voices, but actually changing your relationship to them so that they don't have the same power over you. So there's also all sorts of different ways of working therapeutically with people in that situation. And I think that's particularly important for adolescents, because a lot of some of the research, and I was involved in some of those research many years ago. Adolescents often have periods of time where they experience things that they label as hearing voices. It's a lot more common in adolescence, but most adolescents, and throughout childhood, but most adolescents tend to grow out of that. It tends to reduce as they grow older. So we have to be careful not to jump into the idea that they've got this long-term ailment. One of the worst things that you can do to people growing up is to label them with something that you're saying is lifelong. It's internal to them. It's an illness. It's an example of a broken brain, if you like, or a dysfunction. Because one of the constants about throughout your life, but particularly when you're growing up, is that you will change. All sorts of things are going to change about you. Your body's going to change. Your interests are going to change. Your friendship groups are going to change. Your approach to food is going to change. All sorts of things are going to change as you grow up. And one of the things we shouldn't be doing for any young person is fixing them with the idea that they've got a lifelong. To me, that's like a very dangerous hypnotic suggestion. You should always keep in mind. Yeah.
And I work with adolescents as well. I work in a high school, and at that age, you're so in need of finding an identity, and you embrace that, whatever label it is. It can be positive, it can be negative, but you hold on to it. And yes. I'm also the head of well-being in the school that I'm teaching, and I'm always critical of the curriculum that we're doing. And you have this quote that I've heard you say in your other interviews on how resilience cannot be taught, and yes. I find it very valuable, and it makes me question my own the curriculum that I'm trying to employ, but I also am skeptical about, where do you draw the line? For example, someone who is severely depressed comes to see you and you think they might be suicidal, and there is this transformative power of suffering and pain. And that's how we learn to be resilient, as you say. We experience adversity, we learn that we can survive it. But what do you do when you feel like that person in front of you seems like they cannot maybe like come out of the other way, or maybe they might commit suicide? Like, where do you ever prescribe antidepressants in those kind of maybe more suicidal cases? Like, where do you draw the line in allowing suffering?
Well, the evidence with, of course, antidepressants, particularly in young people, I mean, again, this is a marketing term, there's no such thing as an antidepressant, is that they are likely to increase the likelihood of acting on suicidal feelings. So they're, in the studies compared to the placebo, you're twice as likely to experience suicidal impulses if you're taking an antidepressant. So that's one of the things that you should be very careful not to do. I have ended up prescribing, and that's usually because of a kind of pressure from the young person in conjunction with the parent, and they want to try it. And I've explained in my experience, and I've been over 3 decades working in child and adolescent psychiatry. I've worked in inpatient, outpatient, specialist services, diabetic liaison. I've even started one of the first ADHD clinics in the country back in the mid-1990s, where we took a predominantly psychosocial approach. What I've said is that in my experience, I have yet to come across one person who has been, and I've seen lots of people who've been prescribed antidepressants because it's so widely prescribed, young people from other clinicians or their family doctors. I've yet to come across one young person who has taken an antidepressant and it's led to a sustained recovery. I've seen plenty who've had this, what I call enhanced placebo effect. They might have felt better for a few months, and then afterwards they start to think, it used to work, but it's not working quite the same now. Maybe I need a higher dose. Maybe I need a different antidepressant. I've even seen some strange presentations, like I had a young person who developed the idea that they were, maybe somehow the pill was popping out of their mouth because it used to be working, but it isn't now. So why is it not working any longer? So I have, that's one of my things that I would say to all young people and all families. And if they want to try it, then they try it. But I say it's really important that you consider this as a window of opportunity, because the things that are going to make the long-term difference is, if you do feel a little bit better, what are you going to do? What's going to be? So sometimes if you treat it as a window of opportunity, you can take advantage of this enhanced placebo effect. As far as suicidal feelings concerned, of course, that's a very, very worrying state of mind. And sometimes we do have to take action, which might include suggesting an inpatient unit. So for a period of time, that might be something that is necessary. But one of the things that I've really learned in the course of being a practicing psychiatrist is the most important thing to do is to remember that you're seeing somebody at a moment in time. This is not a permanent state. So the way I talk about the idea of depression, I talk about a state of mind. Depression is not an illness in the same way that, having a broken bone or a diabetes or something that you can find an empirical anchor. It's a state of mind. States of mind are something that we slip into and slip out of again.
Mm-hmm.
And the theory for that state of mind is really powerful. So if you believe that you're experiencing a symptom of an illness, it in effect disempowers you from the idea that you have any capacity for influencing that state of mind, or that that state of mind will shift depending on things that are going on in your life. Without so you become at risk of losing some of your agency, some of your capacity. And the other thing that I've found that's really important in clinical life is to keep alive the idea of hope. And it becomes not that difficult to do that when you're been as long working in the field that I have, because I've seen so many people who've ended up in a really difficult situation in their life, very disabled functionally. Some people who've gone in and out of psychiatric psychiatric inpatient treatment units because they were just unable to function, or have gone in and out of physical hospital for various reasons. And you just have to maintain a patience, and you have to let them know that at some point something will shift, and you don't know how, you don't know why, but you've seen it happen again and again. At some point, something in your mental state will start to make sense. Something will, and I've seen it in various ways. I've seen people who get up one morning and say, I don't want to go on like this. I've seen it in people who've watched a program and it made them rethink. I've seen it in people who've had an argument with their parent, and somehow after the argument, something has shifted. You don't know when it's going to come, how it's going to come. But what I can tell people is be patient. It will come. And it does. I've seen, I've seen people make a complete recovery from one of the most disabling presentations that you can think of. I've seen it again and again. One of the things I sometimes share with people, this is something my wife believes. And my wife has nothing to do with medicine, nothing to do with therapy, nothing to do. She keeps me grounded. And she says to me, look, everybody in their life is going to go through some point where they're in a crisis, where they're, and it's better to get it over and done with in your adolescence. It prepares you for the rest of your life. I like that. I think there's some truth in that.
Yeah.
So it's about not imagining. One of the problems when we start imagining that we have some special power, whether it's through medication, whether it's through some magical therapy, is that if we start saying, yeah, this is the treatment that you need, this is what is going to or should help you recover, and you go through that and you don't recover, is it embeds the idea that, oh my God, I'm even more seriously ill than I thought. Yeah. But it also embeds, especially in doctors, doctors, we're sort of trained with the idea that we can fix people. It's a kind of a God complex that, that we end up being given. So if people are not getting better, kind of as doctors, it can affect our, if you like, narcissistic sense of ability to be a good doctor. And the problem is you then start making bigger and more aggressive interventions. This is when you start adding new medications, new diagnoses. This is how we create long-term patients. This is when we start talking about people being treatment resistant, having a chronic condition, and so on.
I'm so glad that you said it, because the psychiatrists, I think there's a issue with how many psychiatrists, of course, you're a unique case. And if I'd ever have a mental disorder, I'll fly to England and find you because like there aren't many psychiatrists that are critical of this whole enterprise. And also, I was talking with a psychiatrist friend of mine actually, and he was talking about how he's struggling with an academic paper that he needs to write. And I jokingly said, like, just pop a Concerta Ritalin and get it over and done with. And he said, no, I'd never do that. Like he was very conservative about himself taking the drug, but he's so liberal when it comes to prescribing it to his patients, because also they're also complaining that when they prescribe a drug to a patient, the patients feel like that the doctor's done something,
Yes.
other than just let the thing run its own course. So some of the psychiatrists are critical, but they're critical in a way that's like, I don't like it either, but that's what's expected of me, and that's what I gotta do. That's just the name of the game. Coming from that, also, like, you're very critical of this, how these diagnoses have become woven into people's identities, like being a punk or being a goth. But also there's this logical contortion that you also mentioned in your book. It's also a lot of externalization going. Like, I thought it was just me not concentrating or not being successful in this field, but now I know it was my ADHD. It wasn't me. So you externalize the things that you think you couldn't succeed. So it's not an extension of you now. It's just your ADHD doing its work. So at one point, it's a part of the essential identity. Like, I have ADHD. It's part of my identity. But
it functions as me and not me at the same time.
So how do we resolve this? Like, or do we resolve it? Like, do you think people who think they have ADHD have this logical contradiction, or could this be resolved in any way?
I mean, you've highlighted, I guess, something that I've also written about, which is it has this contradiction. As it's got woven, as the mental health industrial complex spread politically, it has got woven into the whole identity politics movement. And so people have started identifying with their diagnoses. I guess you see that in particular with the whole neurodiversity construct. But it goes alongside a belief, instead of a belief that there's something sort of broken inside you, there's a belief that there is some essential difference about you. Either way, you're imagining that the difficulty negotiating our current society is due to something in your brain that marks you out as in some way unfit for society as it is currently organized, which then has a bit of there's an expression in English, you want your cake and eat it. So yeah, I don't know, you might have something similar in Turkish, but it becomes then a way of saying, look, I'm just like everybody else. I just have this essential difference. However, because I have this essential difference, you need to make various accommodations for me. And again, it's not based on any science. So people think, they imagine when they get a diagnosis that somebody has identified something that's essentially different about them. I quote in the book the case of Matilda Boseley, a journalist based in Australia, who talks about how TikTok helped her realize that she had ADHD because the algorithm kept sending her videos of people who had ADHD, which made her wonder. And she talks about how it made her realize that it wasn't that she was lazy. The reason her apartment was always untidy wasn't because she was lazy. It was because she didn't have enough dopamine in her brain. So it makes you reinterpret all sorts of things about your life, and you should be very careful when you start to do that, because my experience is when you start going down this route, where essentially we're talking about a commodity, we're not talking about a condition, because there is no science behind this. This is a kind of a marketing thing. It's very expensive to get ADHD and autism assessments. There's a lot of money being made by that whole industry. Like most commodities, after a while, it doesn't work as well. You might feel liberated to start with, but then after a while, you'll start to question, maybe it's not just ADHD, maybe it's also autism. And so I've seen young people who've gone down that route and come to clinic, and they've already accumulated, by 16, 17-year-old, they've accumulated autism, ADHD, anxiety, PTSD, and now they're coming to clinic because they are worried that there's something else going on. It doesn't quite, and they're now worried that they have a bipolar disorder, and that's why they still can't settle in some way. So that's one of the issues. For me, the other thing we just need to be clear with people about, that these are not scientific constructs. Neurodiversity is not able as a concept to differentiate between a group of people who are neurodivergent and a group of people who are neurotypical, who are sort of oppressing the people who are neurodivergent in this way of thinking. There is no way. By definition, we're all unique. By definition, everybody is neurodiverse, which means it's a pointless concept.
Yeah.
So I just think we need to get rid of it. I don't see any way that we can reform this. Within the whole autism debate, of course, this has sparked a big clash between particularly parents who are dealing with kids who've got significant learning difficulties, who have a lot of needs.
Yeah.
And then the autism advocates who say, no, you shouldn't be viewing your kids as having a disorder, as having a problem. They're just different, and you shouldn't be putting treatments in there. So you're getting all of these divisions taking place around because the concept doesn't make sense. We should just get rid of it. I don't think we can reform these. We should be clear that these are concepts, that they are not scientific, that they are cultural, that they don't lead to liberation of people. They're just leading to an expansion of the medicalization, an expansion of the people turning inwards to try and understand the social challenges that we're all facing, makes social solidarity and the structural changes that we need from our politicians, from our economics, more difficult to achieve.
Yeah.
And so I've become clearer in my mind, looking at these trends, in coming to the conclusion that the only way, really, ultimately, is to make it clear that these are not meaningful concepts, and we need to stop using them.
My final question will be on women and psychiatry, because I'm a feminist and I've been talking with an online therapy platform. They were interested in a sponsorship in my YouTube channel, and they casually mentioned that 90% of their customer base is women. And I feel like this mental health industrial complexes, as you mentioned also in your book, the main clientele market is also women. What do you think? Why do you think this is the case? Why do you think that women are the main market for the mental health industrial complex?
So it is interesting to look at the gender distribution of the psychiatric population, of the population who come forward and either look for or receive formal psychiatric or mental health help. And in children, it's mainly boys. And it's mainly boys brought by their mothers.
Mm-hmm.
And as they grow up,
Freudian.
girls, yep, and girls start to enter the picture in adolescence. And as you go through adolescence, girls gradually become the predominant group. And once you get into adulthood, it becomes women.
Yeah.
And what we've seen in the expansion of ADHD and autism into adulthood, and this is another thing that is the result of what I call a mutation of constructs, not any new discoveries, is that in order for those concepts to expand their market in adulthood, they had to find their way to women. And the concept of masking enabled women to become their biggest
Trojan
growing.
horse.
Their biggest growing. So the idea is you don't have to have the symptoms anymore. You don't have to display the behaviors. You just have to feel that you have them because you're good at camouflaging. You're good at masking those symptoms. So you only see them when you're out of the public eye.
And this masking discourse is also sugar-coated with identity politics as well, because women are always trying better to accommodate to societal pressures. That's why you're doing it, kind of thing.
Exactly. So we should be asking, what is it in terms of the situation with women that means that they seem to be presenting as the predominant group for, if you like, experiencing mental distress? What does that tell us? Surely that is a commentary on something that's going on within our society, within our culture. So instead of turning that into likelihood that you've got problems with your brain, problems inside you, surely it's telling us something about the pressures that are put on women, the expectations to be a competent mother, to have a good career. Where do you get your social, to look good? Where do you get your social value from? Surely it's a commentary on the nature of our culture and our society. So to me, and I think I wrote a little bit about the history of women in psychiatry.
Yes,
this is a long-standing trend. So unfortunately, what is now the mental health industrial complex comes out of a long history of problematizing women and their experience rather than seeing it within the context. To me, there is a real problem when we take out social context from how people understand their life.
Yeah.
Because once you take out social context, because we all have to live in a social context, we all have to live. We don't live in an isolated bubble just with ourselves. We all live in a world where we're interacting with both the stories and the material reality of the world around us. So when you start taking social context out and saying it's something to do with something inside you, you're creating a fantasy world, and you're dealing with a fantasy world. When you deal with a fantasy world, you're never going to change the external world outside you. So, so I think there's a lot for feminists to try and critique and deconstruct with the building blocks for this mental health industrial complex.
Thank you so much. Yes, there's a new alliance between patriarchy and mental health there, definitely. And thank you so much for pointing it out. I'm such an admirer of you, like in your battle, like this David versus Goliath battle between you and the mental health industrial complex. You have a soldier here in Istanbul. And I'll also try to get your book published in Turkish, because I'm also an author myself. I'm a children's books author, so I have some publishing contracts. Like, I'm on a mission. And this is such a valuable book, and thank you so much. You have such a compassionate voice as well, and you're not like this kind of very aggressively, you're very commonsensical, you're so soft spoken. And I could listen to you for hours, seriously. And thank you so much for your time and accepting my invitation. I will end the recording in a minute. Do you have any final words?
Well, just thank you so much for talking to me and inviting me. It's been a very interesting conversation. Sounds to me that like you have quite a lot of deep understanding about the topic.
Thank you. I will end the recording now, but I will ask you to stay for 5 more minutes because the video needs some time to get uploaded.
Okay.
So I will end it now.